Good afternoon and welcome to our session. It's so wonderful to see all of you here. This is an exciting session on artificial intelligence, and I have three wonderful experts with me, and I'm so excited to start this conversation. Starting with the gentleman next to me, Gabriele Ricci. He is Chief Data and Technology Officer at Takeda. And next to him is Nicole Turner-Lee. Nicole is Senior Fellow and Director, Center for Technology Innovation at the Brookings Institute, and author of Digitally Invisible, How the Internet is Creating the New Underclass, due out in August.
That's right.
Yay!
August 6th to be exact.
August 6th to be exact, okay. Can they pre-order on Amazon?
You can.
Okay,
Barnes
good.
Noble,
Okay.
Amazon, wherever books are sold.
Scan the QR code here.
Okay, there you go. And Dr. Stephen Ondra. Steve is a neurosurgeon and chief medical advisor at MITRE, which is a company that advises the Centers for Medicare and Medicaid Services Alliance to Modernize Healthcare. He also, relevantly, was the CEO of Cygnus AI, which worked with AI in radiology. And Steve, I'm going to start with you. When we think of AI, we think of futuristic uses, but AI is currently, as we speak, being used in healthcare. What are some ways it's being used? Maybe some of us here have had diagnostic services that use it, radiological services. Can you set the table for us? How is it being used now?
Well, it's not only being used now, but the truth is it's been used for decades. Mm-hmm. And when we say AI, that is an umbrella term for which there are many different types of machine learning technologies. So right now, large language models are, when people say AI, it's been such a part of the discussion that that's what people think of. But we should think of it even more broadly. So, to your question, it's been used for decades, and there are clinical decision support tools that help healthcare providers do their jobs more efficiently and better that have been around. I remember one 20 years ago that was pretty good at helping prescribe medications and things, and so that's evolved. Now when we moving forward in radiology, diagnostic imaging, that is a place that is already being routinely used, and also clinical decision support. I was at a meeting recently where one of the leaders from Mayo Clinic said they have 250 AI algorithms now being used routinely in care at the Mayo Clinic. There was another neurosurgeon that was discussing an AI algorithm that is starting to be used actively in clinical practice for a really practical purpose. When somebody has a stroke, time is everything. There's a certain subset that can get things called thrombolytics that will break down the blood clot causing the stroke. But you got to get it there fast, otherwise you cause a hemorrhage. And so what they're doing is they have an AI algorithm that will read every brain CAT scan at that institution and other institutions. It will notify the stroke team when the algorithm identifies a potential stroke with no human in the loop. The stroke team then can look at that, assess, and deliver therapy before a radiologist would have ever had the chance to read it. And often the delay can prevent the patient from having the treatment that could have saved brain.
And is that currently being used, or that's
currently being used?
Wow, as we speak. Okay,
yes.
Gotcha. So the rest of the questions are for any of you, and feel free to just interrupt each other and chat, and don't wait for me to say anything, and I'm sure you will. So let's talk about a dream scenario for AI. If you could dream up in 5 years, 10 years, whatever, this is what I want AI to accomplish to solve a current large, big deal health problem in the U.S. Nicole, you're nodding, so let's hear it.
Yeah, no, I think, so just to back up, my work at Brookings really intersects the points of technology, social justice, and race. And I'm really into looking at how we deploy AI from an equity landscape. And so a dream scenario for me as a person who started in telecom, so my book is obviously about the U.S. digital divide, digital invisible is just a play off of that word. Health disparities and health inequities have been very persistent among the medically underserved. And so we've seen over the years these efforts to bring healthcare closer to people who are medically marginalized, whether it's in remote care or telehealth or telemedicine or telepsychiatry. But the challenge has been a couple of things. One is the absence of having infrastructure that allows for us to actually transmit these products and services to people wherever they are. but two, having a greater vision for how things like AI can actually help us when we're thinking about health inequities, meaning, having radiology be something that can be enabled by AI allows for greater decision-making and quick and informed decision-making that can potentially, and I hate to be personal about it, save people like my father who died 6 or 7 years ago because of the lack of access he had to quality care when he was first diagnosed with prostate cancer, but later died from stomach cancer. My point is we need to start seeing tools like AI integrated into these dream scenarios where we have been stuck as a country, as a world, in ensuring that we're getting greater access, greater proximity to solving, I think, a lot of challenges that AI is now offering some optimism about because of its ability to cultivate large data and solve problems.
I want to drill down on that example you just gave. How might AI have helped your father?
So I think
what went wrong and what could AI fix?
So there's a couple of things. I mean, we'll talk about my pessimism about AI, hopefully, too. I'm not always optimistic,
we will.
Right?
Yeah.
I just want to make sure people know that. So the optimism around AI is for people who understand how African-American patients interact with the healthcare system. It's often, one, a point of distrust. Two, there's a lot of misinformation that actually circulates outside of the internet, meaning Black patients often do not ask the right questions, and doctors often do not inquire about irregularities that they may see in the screening. One, because we're not always telling the truth. My dad was a smoker. He ate really bad food. He didn't tell all that. He just talked about where his pain was at that moment. My ideal scenario is if we had AI, the clinician that was actually working with him potentially could have compared his efforts against others, right? That there could have been some thresholds of concern that would have showed up. In his particular case, the cancer had migrated to the stomach, and the doctor was treating the prostate, right? And so because the doctor, and I think many of us who are in this space know that they're only dealing with the tools that they had. They're almost like the AAA guy, right? He's only got what's in the truck, doesn't have everything else that is available to help us, maximize. I mean, I'm being honest about it, right? He can't do a whole lot of stuff except put it on his toe and take you to a mechanic. My point is, for healthcare, we need to bring those tools closer to the clinician, and we're getting in spaces like radiology where it's better. It's not always better in some of the maternal areas. We could talk about that. But in certain spaces where AI is collecting the right data and it's a little bit more representative, I always share, and I spoke about this actually before the Association of Gastroenterologists, if we had AI at work in this positive use case where we could have actually compared his condition, he probably would have been, I don't know if he would have lived or be living today, but he would have lived longer, which is something, again, we're not using those tools right at our disposal to make those kind of decisions.
Gabriela, your dream scenario.
My dream is that these AI tools could be for doctors as common as the stethoscopes. A tool that is easy to use. I mean, I never use a stethoscope, but I suppose it's easy to use.
It's better than the AAA analogy. I'm just saying. Just saying. I don't know where that came from. Okay.
So this is simple. That is probably the first tool used by every doctor, right, to be trained of. That could be cheap as well. So it's like a tool used by the medical teammate to really, work in the back end, analyze large volumes of data, inform better decisions, as you said, like a teammate, if you want, for the medical teams. And actually making the invisible visible. We are just not designed to process large volumes of data. We don't have the precisions that these tools could have. And so they can actually really create better outcomes, right, for the medical teams.
AI is often mentioned for a couple of things. Radiology, one that we've mentioned already, but also drug development. So you're not sort of going through one thing after another you can do. So could you please tell us all your trade secrets about what Takeda, in what way, I'm looking out to the Takeda team here. Could you please tell us all your trade secrets about how Takeda is using AI in drug discovery?
Is using AI to understand really how the structure of proteins, for example, interacts with human biology. Is actually accelerating also the trials, how we select patients, for example, for trials, or the site for trials. How we can personalize the experience for patients in these trials is really across the entire value chain. How we manufacture and produce our drugs, how actually we deliver our drugs, the experience, right, after treatments. So it's really across the entire value chain. Sometimes AI manifests in a very obvious way, some other times in a less obvious way, like, the entire value chain around the drug discovery and drug delivery.
I have an additional dream.
Uh-oh. Let's hear it.
My dream, if I had $1 billion to invest, where I would put it is on data and how to get data, which ties to equity. I was at attended a genomics panel that MITRE had earlier, talking about the amazing work being done in genomics and tying that to health information and the potential of that. And AI algorithms are just algorithms. They're only as good as the training sets that they're trained on. And those training sets, and now we'll really talk about large language models in particular, those training sets are often have a paucity of clinical information right now and a lack of physiologic underpinning. And so purposefully developing data sets that are clinically relevant and physiologically sound and truly representative. The NIH has had a program for, I think a decade or more, called All of Us, working to get 1 million people with intentional making sure it's representative of the whole population, therefore all of us. And I think there are 800,000 people into it now, tying a variety of records, including the genome. That kind of data information. And I said earlier that MITRE serves government and government serves you, although it doesn't always feel like it, but that's what it does. And so government is actually leaning forward at helping identify ways that we can aggregate data, whether it's the All of Us program or the Million Veterans program and other work that's ongoing. And so I think getting those data sets so we can train algorithms specific for healthcare and not adapt algorithms that were made for something else.
Can I jump in there? So I think that's actually a fantastic suggestion, because data is what's driving a lot of these machine learning models. And as we talked about earlier, where we are today in the AI continuum, we've talked a lot about predictive AI, but there's also generative AI and more frontier models coming forth that I think are going to just have greater capacity than what we're actually able to do with just predictive models. With that being said, data quality is essential in healthcare. I cannot repeat that enough. And I think it starts with who is involved with the clinical trials. A lot of the work that I do is really about, and it kind of goes back to my story I shared earlier, who's sitting at the table when we're actually thinking about how this data is being funneled into the AI models. What representation from a DNA, a genome perspective is being included in these data sets, and what is the absence of that equity information going to do when it comes to making sure the AI models are right. So I'll give you a perfect example. I just finished a paper, it'll be out in a couple of weeks, on AI use among the public healthcare workforce, right? And so one of the areas that came up is that we have a really vibrant public healthcare workforce because, people who are medically marginalized tend to rely upon the public health workforce. There's a lot of trust there, right? But if we put AI models in the mix, they may not be represented or seen in some of these models, or the decision may be wrong. And so I think it's really important, we talked about this, that we really get the data science right on this. Yeah. Healthcare data comes with traumatized remnants. What do I mean by that? Henrietta Lacks, Tuskegee experiment. There are examples, women who have been misdiagnosed because of their lack of inclusion in clinical trials that test pain threshold. They're tested on men and then they're applied on women. We've got to do a better job of really starting at who's at the table when we're actually harnessing these data, and then figuring out if there are holes or blind spots in the data or the data science, disclosing that so that we don't have public health professionals and new doctors saying, hey, I'm gonna start using AI because I think this is gonna be a great solution for expeditiously getting through clinical diagnosis, but it's actually missing a large portion of people.
In the second tap, after we get the data right, will be the issue of assurance that the algorithm is working right.
Yeah.
So we say there's two questions. How much do you trust the information that it's giving you when it's working right? And two, how do you know it's working right?
That's the key.
And so that's AI assurance, and that's something that will take, no one group is going to do that. Government alone can't do that. It will really take a collaborative public-private effort. And that's probably right up your wheelhouse in terms of drug development.
And I think also, coming back to to data is quality, is volume, but also about ownership. And I think it will become, for sure, a human right. Who owns data? Who's using my data? For what scope? How data is propagated? I think will become basically a social divide, if you want. Definitely would be an accelerator, but could create a completely new ways, actually, to create health equity, right? So data ownership, I think, will be crucial for the future.
When I talk to folks I know about AI, so these are not healthcare experts in particular, they seem to fall into two camps. One camp is, oh my God, that's so exciting. It could cure this, it could cure that. Look what it could do for this, look what it could do for that. Bring it on. The other camp is, no way. Artificial intelligence used in my healthcare? No, it's gonna mess things up. It's not gonna be representative of me. It's going to lead down a road that's wrong and no one will catch it. Use AI for other stuff, but not my healthcare. Thank you very much. Is the truth sort of somewhere in the middle?
It's an issue of healthcare literacy, of helping people understand. When you don't understand something, you're afraid of it.
Yeah.
And so it's helping people understand how AI is part of their life. You know, what is it, on your next iPhone, it's going to have AI tools that I think you can either opt in or opt out of. It's part of our lives now, and it's helping people understand that, and then making sure that they have the assurances for privacy, for functionality, and for relevance to them.
It's like actually trusting a person. Why you trust a person? Because he's a professional, because of his background, because actually, is trustable, right? Maybe because you have a personal chemistry. I think would be the same with AI. It creates actually new areas where we need to look at bias and fairness, for example, how you manage bias and discriminations, how you ensure that the AI system can create equitable outcomes, for example, is about the lack of transparency, how you ensure that you can explain how these AI systems can make decisions, is about accountability. Who owns these algorithms? It's not just one shot. It's not that you create an algorithm and it's done. It's actually a continuous training. Who's responsible?
But wouldn't the
managing
company who
bias.
wrote the algorithm own it? I mean,
Well,
who else would own it?
I think who is committed to create reliable, trustable, and equitable solutions. If we create something around our therapies to augment actually the output or the outcomes for patients, we are responsible. We are responsible to continuously train these algorithms to managing risks and mitigate risks, to check bias and discriminations, to actually make this auditable and increase the explainability of these algorithms, the data privacy and data security. Remember that all these algorithms are actually using and they're trained on somebody else's data. We don't own this data. And more importantly, the data privacy and data security is about working in an industry that is very regulated with policies and regulations that are constantly changing across the globe. So we need to constantly comply with these regulations. We are responsible for that.
Yeah. And if I could just jump in, so I think to your friends, some of that has to do with this conflation between AI for efficiency and AI for clinical practice. So let me tell you what I mean by that. Many of us in this room, when we adopted into our electronic health records, may not realize that there's some AI being embedded in the efficiency, right? I was my doctor the other day, and he was recommending, I have a penicillin allergy, he was recommending different medications and derivatives of medications. Well, AI is probably powering that system, whether you know it or not, because it's no longer the drop-down menu in some type of Excel spreadsheet, right, that's doing that. So I think people, have this thing where they think the AI is this, when really it's a both and, right? There's efficiency applications that are helping our medical management better, our patient care profiles better. It's helping us to think through, whether or not we're scheduling correctly. And it's helping people as well to make sure they're keeping their schedules and keeping to their preventative plans. It's the part on the clinical practice that people really are scared of.
Yes.
And as a policymaker, I'm in DC, we're constantly trying to figure out then what is the way that we regulate trust and safety. So we've talked a lot about trustworthy AI, responsible AI, inclusive AI. Now we've added trust and safety, meaning what are the assurances that people have that, one, that the AI is going to be used the way it's been designed, and two, it's not going to make a mistake, particularly about our healthcare. The challenge is, and I'll put it kind of on what we were talking about, who owns the AI and who's liable is still a question of concern, right? We don't know who's real. I mean, you can't sue an algorithm, right? And you just can't. I keep telling people the algorithm cannot go to court.
But can you sue the folks who came up with the algorithm?
You might. And part of it is it could be not just the company, it could be the developer that the company used, it could be the third party. You know, it's really confusing right now in Washington, D.C., because a lot of that is not disclosed. We don't know how the AI becomes an iterative product from the ideation phase to when it's actually there. I would suggest we've got to iron that out. But another thing we need to iron out in healthcare is indemnification. So how do people have agency over things that happen to their, diagnosis or physical bodies when AI is used? And I kind of called out Henrietta Lacks, because when I got into this space, it was really poignant for me. If you don't know, she was a Black woman whose DNA was used to cure cancer. She died a poor woman because she was never actually compensated for the use of her DNA, but also, she didn't know it was being used in these things. Part of the challenge going forward may be this conversation of balancing who makes it versus how do people speak up. And that's, in my work, how do you develop a conscious feedback loop where you can work collaboratively across sectors, across civil society, across patient advocates to hit the right middle. And I think that's the area in policy we're still trying to figure out. How do you balance that process so you could still innovate in healthcare without it being something that people are just insanely afraid to use?
And the issue of regulation is a really complicated one, because the regulatory frameworks we have are made for static, fairly static medical devices. They're really focused on before they come to market assessments. For AI, these things will continue to change. The population itself will continue to change. Where it's applied will change. And by the way, an algorithm not related applied to that population will change that population.
That's right.
So this means we have to think about the regulatory framework in an entirely different way, really, for after release continued monitoring. There's no federal agency large, the whole federal government probably isn't large enough to do that. And so we have to sort out how does industry develop best practices? What's the role of government in the most high-risk areas? And then what are the roles of coalitions? MITRE helped form the Coalition for Health AI, which is a large public-private group. It is now a separate organization, which is what we like to do, solve big problems. That's going to solve this a piece of one, and then birth it off and move on to the next one. But it'll be all these pieces to really think about regulation in a very different way.
Right. So Steve, I know that you're not with the FDA, but I'm going to kind of pretend that you are for a minute. Does the FDA currently say, all right, so you have an AI algorithm to do X, let's say it's radiology for mammograms. It is based on data from X number of women. We're going to require that number be reflective of the U.S. population. This % Black women, this % Hispanic, et cetera, et cetera. Do they currently require that? Like, is that written in stone somewhere?
No, it's not written in stone, but I will say, we advise, across government, including all of HHS and the FDA. And I get to talk with the public and private sector across the board. Some of the most sophisticated thinkers on this are at the FDA.
They really are.
And so that should hearten people. They don't have it figured out, but they are working to figure it out and actively working with the private sector and leading some efforts. So I think that large language models in particular, this generative AI, are new enough that nobody quite has their arms around it. But we have some of the really sophisticated minds looking at how we do this, but how we do it right.
But so that's what you're saying is they don't. Well, I mean, could I get my AI algorithm that was based on data from 100% white women? Could I get that authorized by the FDA?
Well, you go ahead and I'll tell, because I just saw,
My recommendation, and this is what we're trying to do, because this is a space that is, evolving so quickly, is to create your own ethical AI framework. that actually create the guardrails for the organization to start questioning exactly what you said. Is it okay to use Western data to create early diagnostic tools, for example, for rare conditions, and repurpose this algorithm in Asia? We operate in 80 countries. These are exactly, the questions that we are always asking ourselves. Is it okay? Or actually how we can use data sets that are representative of the populations that we want to serve. The unintended consequences of actually using data sets for a specific purpose and actually change the scope could create bias, could create discrimination, unexpected outcomes, and risk for the customers, for patients. So creating those guardrails internally in the organization, seeking for external support. For example, in Takeda, we have Takeda Ethical Advisory Council that is composed by internal and external experts that really help the organization understanding what are the risks of emerging technology. It's not just, let's say, tech, right? But it's also science. How we can ask our these kind of questions internally and create the strategies, right, to mitigate those risks.
So you look like a trustworthy guy, but do you think do you think the American public might say, "I'm going to trust you to make sure that you try this out on"?
Well, is about how you build your solutions, and as I said before, it's about clarifying the accountability. Is about creating the ethical principles around you want to operate. It's about the transparency and explainability of these tools. It's about the auditability of these tools. It's about the continuous monitoring and risk mitigation that you want to apply. It's about the data governance that you want to put in place. It's about data privacy and data security. It's about bias management and how you react to unexpected consequences. It's about collaboration and how you actually ask external auditors to come. So is the entire, let's say, framework that you need to build in order to be a trusted partner.
Nicole, I see you taking a lot of notes.
Yeah, I mean, I was taking notes. So I had an opportunity to hear Chair Cahill at the White House just hosted a summit in D.C. on AI aspirations. So all the secretaries and chair people came up, and he's been pretty consistent at the FDA around bias mitigation and ensuring very equitable and fair, particularly diversely fair models. But one thing about the FDA I think is worth mentioning, it's very easy for them to regulate medical devices. So I've had the opportunity to see them talk about what I think are some really good best practices that we've heard already, which is, what are high-risk scenarios for AI outputs? Where are the areas in which we have to give the type of regulatory green light because we know it's not going to have a consequential output? And they're really doing that for people in this room. There's like a really good amount of smart people working through those challenges. And then I also think at the HHS and other places, even the CDC, I've done stuff with the CDC, they're constantly thinking about ways in which to raise the level of awareness and literacy while also thinking about what they can regulate. But I want us to be cautious because this is a technology that is not a medical device, right? Medical device models may be empowered by AI, but many of these are behavioral outputs, right? AI is very much a consequence of who is sitting at the table in the design of the model, what data is training it, how the AI output is being interpreted also matters, right? And the context in which the AI is employed. We look at a lot of just outside of AI, we look at healthcare in general, we look at COVID. The pandemic is a great example of this. A lot of people died in the pandemic. Some of them died because they actually got the virus. Some of them died because they got the virus because of their housing condition, because of their access to healthcare, because they were frontline workers, because they were already compromised medically. What we have to do with AI is to continue to consider those behavioral outputs, but in a way that balances, I think, the growth of innovation. So to your point, Elizabeth, it's hard because I, as a person who believes in health equity, do not want to say, well, don't use AI if it can actually help us to manage some of these health equity concerns. I think the key thing is we want a balance where there's innovation, but there's also guardrails, where we have stops of feedback loops where we could determine if there's differential treatment of populations or disparate impact. I unfortunately think that patients themselves are 2 to 3 degrees removed from the AI. When we go to the doctor, we're coming in for a particular medical concern. We're not saying, hey, by the way, did you use AI? And was it trained on people that look like me? And what was the confidence threshold? And while you're at it, I want to see all the code. I mean, we're not doing that, right? We make trade-offs as patients all the time on these things. The challenge that we deal with in Washington, and I'm a sociologist, structurally, is that we can't figure out which part of it we have to pay attention to. Is it disclosure? Is it, some type of consortium that can determine which areas are ready for prime time, which areas need more work? Is it a conversation around data governance? I think until we start to think about what I call like the components that actually operate the AI machine in these contexts, because I can tell you, the same thing happens in education. The same thing is happening in hiring. The same thing is happening in criminal justice, because these are high-risk contexts that have consequential outcomes that the people where the AI is being used, they cannot mitigate the foreclosure of what the outcome is because they don't know how it was built.
And, I never answered your question directly. I want to thank my colleagues for giving me time to think. What a gift. I don't know that the FDA has hard and fast rules, but I do know that they are looking at the data sets that it's trained on, because having led an AI company, I can tell you that we did entire studies for product, had it ready to go to market, and the FDA turned back and said, yeah, your data set isn't fully representative. It's like, oh, seriously. And so, and then it's also, what you mentioned, context is important in a variety of ways, but one of them is, what is the AI being used for? And in some cases, full representation, immensely important. In other areas, important, but less so. In others, not much. Lung nodules, probably not that much. If breast cancer, huge issue of representation. And so I think that government is struggling with all the things you talked about, but they're actively working and thinking at it, and also understanding the context, because if you use down to the angstrom measurement for something that a ruler would be fined for, that's wasteful of resources, and the FDA has finite resources. And so they're trying to understand what context and what level of representation and fidelity is needed.
Yes.
Oh, I'm sorry, I thought you were going to say something. So let's talk a little bit about AI used in ways that consumers can relate to, which is when you Google something, right? And so for, many, many years now, we have all been Googling our health problems and getting answers. Do you feel like AI, and sometimes good and sometimes not, but do you feel like AI is going to make a difference down the road? Are we going to get better answers because of AI?
So I'll start as the pessimist, in all honesty. I think the velocity of misinformation, particularly health misinformation, is going to be empowered by these searches that have much more sophisticated underpinnings. Meaning, people are going to do the typical search of, we all do it, so no one in here should not say you do. Why is my knee hurting, right? And it'll tell you all the reasons. But the challenge is we now have big companies that are not necessarily doing health and medical specialty information using other tools that are generating response. So, generative AI in particular is able to generate responses that scrapes the internet. That is definitely not looking at representation on who said what. It's basically taking what they think is the best mind answer. Right. It's not always language specific. There are 700 languages pretty much that generative AI is trained on. So that means it's skipping a whole lot of people in terms of that condition. So I'm the pessimist here. I think health misinformation is probably going to be, we talk about election misinformation. I think health misinformation is just as bad, because what that means is people who are already distrustful are going to feel that, they're not getting the right information. If they go to their doctor and say, well, the internet told me my knee hurt because of this, you're telling me my knee hurts because it's an underlying condition. We really need to do that media literacy around that. And we, in many ways, I don't want to use the word disembowel, but sort of, we had this movement of technology where we were primarily analog. Through policy, we're very digitized, right? We've thrown away the analog approach to how we look at problems. We literally go to everything digitized to make that work. And in health, we went to digitize remote devices and other things to help us mitigate and give us some agency over our condition. The challenge is companies took advantage of that and are now harnessing what's publicly available to come up with, ways in which they can make that even sharper. But it doesn't mean it's ethical, and it doesn't mean it's right. I would love to see in a dream scenario where we actually see more health companies and pharmaceutical companies sort of come up with trusted engines for things like that. I've talked about that in financial services. We haven't developed clearly like a good alternative market. So when consumers are trying to find that information, they know, okay, this has been tested for bias. This is maybe not applicable to everything, but it discloses that. And I think, to me, that's going to be our biggest challenge.
Can there be, to help with that, in terms of these assurance and other labs assessing AI, now I'm going to date myself, a good housekeeping seal.
I talk about that too. You're not dating yourself. I talk about that all the time.
So when you're getting information, that you have some vetting of the accuracy of that information.
Yes.
So I think
I have a positive,
go ahead. Yes, please.
Positive view.
Go ahead.
You said positive.
Just to be positive.
He said, by the way.
As internet transformed completely the way in which we access actual information and knowledge in the 90s, it will happen the same with AI. Actually, we'll amplifying even more access, we'll create more personalized information, more accurate information. I think we'll completely transform healthcare. We need time. If you remember in the 90s how you connect to internet, there was a modem, all the noises.
I talk about that in my book. I'm not as old. I'm not as young as I look.
We are at the same stage. Yes. But I would also love to consider that all these, AI companions or whatever, for example, in organizations like us, I would love really to consider them like digital interns. What I mean is that if you have an intern, you don't start giving very challenging assignments. You start with very easy task, and then you check, the outcome. Maybe you want to supervise how it works. This is the human in the loop, by the way, it's very important. And then over time, you get confidence, and you give it something more. And then and by the way, an intern can, grow in the organization, can be promoted in the organization. Would be the same with these AI companions. It just take time.
Can I say something on that?
Sure.
Because I love that. I had an opportunity maybe 4 months ago to see an AI-assisted nurse, right? And so they come on and they say, hello, how are you today? And I was in this conversation. I was like, wow, this is like kind of cool, because people who are by themselves or maybe lonely or want to make the AI assistant can come in and say, have you taken your medication today? Are you doing better? To take your temperature. And then I went to a conference of philosophers who were basically talking about these chatbots. And they were like, but the problem is they're not empathetic chatbots.
Yet.
Right? Right? They're the interns, but they're not the ones that can dig into that empathy, and that trustedness that comes with, folks. And these particular groups of people I was talking to, they were philosophers who do health work, but are interested in like the Hippocratic Oath, and very much tied to just the ethics of how you deliver patient care and how you engage with your patients. I think that's a conversation, to your point, right? We're going to have, like the extent to which AI will get past the intern stage and in what context and what scenarios, which I think is important for people listening. There's no one silver bullet, right? This is going to be an iterative conversation that will probably keep changing. The only challenge is that the technology changes before we change or we get to it.
And talk about that stepwise. It made a lot of headlines when ChatGPT 4 passed the USMLE medical exam.
Yes.
Now that didn't surprise me too much, because if you think about it, those exams are based off known bodies of data, literature, books that can be ingested, and I would expect that an algorithm would do pretty good on that. That's an entirely different thing than applying it to a patient in front of you who isn't a textbook, who has all sorts of conflating factors. And so I share the excitement and believe in the potential of how this will transform healthcare, hopefully for the better, hopefully for more equity, for better access, higher quality. We just need to be careful that we shepherd this in a stepwise fashion.
That's great. Well, wonderful. Well, we would love to take some audience questions now. So raise your hand. I see someone way in the back there. We'll start with you.
So I actually have two.
Oh, and first say who you are and who you're with.
Maria Mesa. I have a company that builds healthcare software and video games. If you can talk about a case where you have seen AI deployed, where it has caused more harm or inequity, that's one. And two, what are your thoughts in terms of using technology such as blockchain to explain and to track how these algorithms work, and potentially at some point to track ownership and potentially, as it should, monetization of the data by us, which are the patients that our data is being used by companies to produce knowledge and drugs and all of these things. Right. So blockchain and harmful or bad outcomes in AI.
I'll take the first one, and then I'll leave it to these two to do the blockchain. I'm going to go first, so you all can take that one.
Thank you.
Okay. I'll let you know. I was like, I've heard the second one. I'm not going to answer that one. So the first one, I'll give you a really good example that's recent, right? Because there are other examples, but just like in the AI space, we don't have enough feedback from consumers or patients on how this technology is interacting with them. The same way we have challenges when it comes to overall technology. But one great example to think about was the pulsometer. So there was the use of it for, am I doing it right with the pulse, the blood?
Oh, yeah.
Yeah. Yep.
Pulse oximeter.
Oximeter, that's it.
There you go.
And so basically what happened was this was being deployed to Black patients to sort of get their readings so that they were able to report that back to doctors. But what the developers didn't realize that any type of biometric identification system that is empowered by AI currently has the inability to look for darker skin complexions. And so the light was not giving adequate readings to people who were using it, whose hands were brown, or darker. And as a result, they were registering wrong counts and wrong outputs. And that essentially became a problem. When it was seen as an opportunity, it actually became a problem in terms of, how that data was actually being measured and taken in. Now, some of you might say, well, wasn't that, kind of primarily focused on this particular function? It really is part of the embedded technology of facial recognition that some of us have heard that has had a hard time really being able to discern the distinctions in melanin tones and act, in a way that is optimized for greater performance. We've seen so many people just in facial recognition, you wouldn't believe it. I do this thing at the airport because I change my hair often. I wear my glasses sometimes. Sometimes I pull back in the light. They are always asking me for ID because they cannot say who I am, right? And people,
do you have several?
I know, right? Imagine I am legal at this point with I'm not coming in to, trying to get past without an ID, from that standpoint. But this is like real stuff. And in the facial recognition side, we've seen, for example, Black defendants, particularly in the city of Detroit, be arrested and seen as convicted felons because the facial recognition picked them up as somebody else. Mm-hmm. And so when they applied it to healthcare, it was the same outcome. So that's where I think it's a technology that overall goes back to the assurances that it's going to work correctly on certain populations. And that's when we had to abandon because people were registering wrong and it was going to have an output on their care. So I'll leave it to you.
On the blockchain.
The second one,
yeah, right.
Blockchain.
Okay.
So I think it's a great idea. There are already examples of using blockchain basically as a distributed ledger to track ownership and who's consuming basically our own data. Now, the problem is how we distribute the value across the ecosystem. Because now the value is actually very unbalanced, right, to some, let's say, actors in the healthcare ecosystem. So blockchain would be a fantastic solution. My wallet is actually, will contain my health information and not only. And then I can decide who's accessing what and keep track about how my data is going to be moved, right? But distributing value and controlling the value is complicated. That's my perspective.
It is, and it's risky from a power perspective.
Yeah.
Because not many people in this world actually own their data or are understanding what it means to have sovereignty over your data as well.
We have a question here in the front row.
Hi there, I'm Dora Green. I'm Director of Health Equity at Takeda.
So you need to answer.
This is not a plugged question. This is my own question. So we talked about the future and innovation around AI, specifically around data sets. So how do we regulate the access of data sets across public and private organizations, thinking about, I'm thinking hospital systems. They may tell a public institution, hey, we can give it to you for this amount of money, where a public institution may not be able to afford it. And then a larger institution, like a Google, sorry to anyone who's from Google here, may be able to say, yeah, we can give you billions of dollars for that. So how do we regulate that?
One of the things, in fact, Gabriella and I were talking about this yesterday, is I would like, you talk about dreams, I would like to see that data, the identified data, publicly available. A little bit like how NOAA makes the weather data available to the public. All the apps you have on your phone are using the same exact data set from NOAA. And it's how their algorithm processes that data that differentiates them. That's what I would like to see in this, because it would not only allow big companies to access that, it would empower innovative startup companies who can't afford that. And then if you realize the dream of an innovative startup company, be acquired by Takeda, when you come up with a blockbuster, that's good for everybody. And so I think finding ways to make this publicly available would be a really positive outcome.
And I would just say, Dora, what I've argued is I think in cases like that, we need more regulatory sandboxes and safe harbors, right? So that we do some co-evolving of the data sets, particularly among data sets that will reveal some, very ethical challenges when it comes to whether or not people are opting into that. I do worry, it's another conversation for another panel, about data monetization and access to data because of the critical injustices that have been done to groups when their data was available. So I think it's important for us to do a couple of things: find regulatory safe harbors, more partnerships with historically Black colleges and Hispanic serving organizations and organizations that are thinking about community advocacy and patient care. You wouldn't believe it. There's a whole avoidance of how community clinics actually interact with AI. Oftentimes they can't because they don't have the latest radiology equipment, they don't have the tools. So just thinking about how do you do it in a way that is protecting the patient, but also protecting the sovereignty of the data, as well as making sure we're using it not for market incentive, but really to make it better in terms of healthcare system.
And accelerate innovation.
Yes, and accelerating innovation at the same time.
I think we have time for one more question. Go ahead, right there.
This was an amazing group, by the way. My name is Nana Fomanin. I'm an emergency physician and Chief Medical and Innovation Officer at Harvest. And I have been fascinated by this and jumping into this since 2020. And the reason why is because during the pandemic, we shifted to telehealth. I love ER. People don't like ER, who's in medicine, but it is one step in the community, one step in the hospital. And so I was like, wait a minute, 60% of my patients are not going to be on telehealth. And so we started working with community churches, and we built these tech hubs where at the churches they would drive through, and we would set up these tech setups. And we realized how many people in the community didn't know how to even access or use the iPad. That set off a whole study around digital divide, which set a whole opportunity to teach and create masters and leaders within the community who were dealing with this. Mm-hmm. So then I was like, okay, AI is coming, so let us work with them to see how they can help and be part of this. Mm-hmm. So one of my questions is around this whole thing about billing, right? In the emergency department, the most important thing is emergency diagnostics. If you don't tell me how you're feeling in the right way, I'm going to do what the nurses do, which is check off all the wrong things. I come back in, and it's a whole different story. How do we get to a point where a patient could tell their story in the way they want to tell their story? And could AI be the augment ability to do that? So instead of it looking at it's easier for the provider, could the patient come in and say, I'm feeling this way and this way and that way. ChatGPT spits out, this is what you want to tell the provider. And they're like, that's not the right thing. Because that's what ChatGPT is. It's a dialogue. It's to reiterate and iterate the story. So by the time they get to the provider, they're actually feeling better and they actually believe that they're telling the right story. And the provider gets a chance to actually process the idea about the diagnostic and the treatment. And it goes back to what you were talking about in terms of the intern, right? For patients who have a lot of distrust in the community, they are like interns and like they don't know how to talk to providers and then they just stay away. And what is different, I want to argue about looking up your issue or your diagnosis online is that you don't get that feedback like ChatGPT gives you. So if you look it up and it says you have this, then you go to your provider and they're like, that's not it, and you're just arguing with them. It's different to see the ChatGPT and say, well, maybe this was reiterated.
Have you tried selling this idea? It's a
I know. I was
great
gonna say,
idea.
Yeah, well, it's
Maybe someone in the room here.
we're in Aspen, right? Big ideas.
right.
But the reason
I mean,
why
do
I'm
you-
coming
do you
back
see-
to the
is there-
question.
is there
Yeah,
a-
I mean, I would say this, just two things, and I know we have to wrap up. First and foremost, for everybody in the room, we have to close the digital divide because we will create an AI divide because you need infrastructure, you need ecosystem, whether it's the hospital, the church, or whatever the ecosystem is, but they all have to be connected. But I would say on your second piece, just keep this in mind. There are more subject matter experts coming to the table to develop these products, more than what we've seen before, where they're actually part of the co-creation. What do I mean by that? We need those kind of environments to help a ChatGPT that honestly may not be specific to older people and how they think about technology, but having them at the table to help develop those products and services. I think we're at that stage in AI where more people are seeing we can break out of the traditional mode, but bring more actors in to help us. I was just on a panel just the other day with a guy who's developing Black ChatGPT, who's looking at some of the vernacular. We can do the same when it comes to health education. What does that look like for this particular context and audience? I'm going to stop talking because I think we're out of time.
We are, but
We're
thank
about to
you
get
all
kicked out.
so much.
Thank you. Thank you.
You were all terrific. Just wonderful.